So let us start with our discussion with the arteries. So here the middle meningeal artery. The middle meningeal artery is a main artery which is arising from the maxillary artery. So maxillary artery is the main important an artery which is present within the infratemporal fossa, and the maxillary artery is a branch of external carotid artery. The external carotid artery is terminating by dividing into the maxillary artery and superficial temporal artery. Now the course of the maxillary artery is divided into three parts by lower head of lateral pterygoid muscle. The lower head of lateral pterygoid muscle divides the course of the artery into three parts. So from the first part of the maxillary artery, 5 branches arises: deep auricular artery, anterior tympanic artery, middle meningeal artery, accessory meningeal artery, and inferior alveolar artery. Deep auricular artery and anterior tympanic artery, they supply the tympanic membrane and middle ear. Then the middle meningeal artery, which is a clinically important branch arising from the first part of the maxillary artery. Now this middle meningeal artery enters into the skull through foramen spinosum. In the infratemporal fossa, the vertical course of this middle meningeal artery is being looped by auriculotemporal nerve. So the nerve which is forming a loop around the middle meningeal artery is auriculotemporal nerve. Then after entering into the foramen middle cranial fossa through foramen spinosum, the nerve divides into the artery divides into an anterior branch and posterior branch. The anterior branch runs deep to pterion. So the blood vessel which lies deep to pterion. Pterion is a meeting point where the frontal bone, parietal bone, then the greater wing of sphenoid bone, and squamous part of the temporal bone, the H-shaped suture intervening in between these 4 bones, you call it as pterion. Now what is the blood vessel which lies deep to pterion is anterior branch of middle meningeal artery. Then this middle meningeal artery runs vertically upwards just 1 centimeter behind the coronal suture, and this anterior division of middle meningeal artery corresponds to motor cortex. It overlies the motor cortex. So the middle meningeal artery is the artery which is commonly subjected to extradural hemorrhage. The artery which is subjected to extradural hemorrhage is middle meningeal artery. So 3 points what you have to remember is, it is a branch arising from first part of maxillary artery. It enters into the skull through foramen spinosum along with nervus spinosus, a sensory branch of mandibular nerve, and the course of the middle meningeal artery is being looped by auriculotemporal nerve. Then after entering into the skull, it is dividing into anterior division and posterior division. The anterior division lies deep to pterion, and its distribution corresponds with the motor cortex of cerebral hemisphere. Then after that you find accessory meningeal artery. Accessory meningeal artery passes through foramen ovale. Middle meningeal artery passes through foramen spinosum. Along with mandibular nerve, accessory meningeal artery passes through foramen ovale. Then the chief source of blood supply to the lower jaw is inferior alveolar artery. Then from the second part of maxillary artery, that is the portion which is related to lateral pterygoid muscle, this part gives rise to all muscular branches. You find pterygoid branches, then mesenteric branch, buccal branch. So those are the branches which are being given by the and deep temporal branches arising from the second part of maxillary artery. The third part of maxillary artery gives rise to posterior superior alveolar artery. So which is the chief source of blood supply to the maxillary air sinus and upper jaw. Posterior superior alveolar artery. Then infraorbital artery, which passes in the infraorbital groove, infraorbital canal, and comes out through infraorbital foramen. Then greater palatine artery. Then an important branch called sphenopalatine artery. The sphenopalatine artery is the artery of epistaxis. It is the chief source of blood supply to the lateral wall of the nose and nasal septum. In the anteroinferior part of the nasal septum, there is an area of anastomosis between 4 branches. In the anteroinferior part of the nasal septum, anterior rhythmoidal artery, septal branch of facial artery, greater palatine artery, and sphenopalatine artery. These 3 arteries are mainly anterhythmoidal sometimes. Mainly sphenopalatine artery, greater palatine artery, a branch of maxillary artery, and septal branch of facial artery. They take part in the anastomosis in the anteroinferior part of the nasal septum. This area of anastomosis is called Little's area or Kisselbach's plexus. So the chief artery which is taking part in that anastomosis is sphenopalatine artery. So artery of epistaxis is sphenopalatine. Then pharyngeal artery, artery of pterygoid canal. So these are the branches arising from third part of maxillary artery. So course of maxillary artery is divided into three parts by lower head of lateral pterygoid muscle, and the main branches arising from the first part, deep auricular, anterior tympanic, middle meningeal, accessory meningeal and inferior alveolar. Accessory meningeal artery passes through foramen ovale, middle meningeal artery passes through foramen spinosum. And the clinical importance of middle meningeal artery is it is the chief cause of extradural hemorrhage, and it is looped by auriculotemporal nerve. Anterior division lies deep to pterion and the distribution overlies the motor cortex. Then from the third part you try to remember that sphenopalatine artery, an artery of epistaxis. So here middle meningeal artery overlies motor cortex. It is a branch from first part of maxillary artery. So option B is wrong. Then it overlies somatic sensory cortex. So that option is wrong. It enters into the cerebral cortex through foramen ovale. It is passing through foramen spinosum. So the answer is A. It has been wrongly labeled there. The answer is A. Then which is not a branch of internal maxillary artery. Internal maxillary artery or maxillary artery both mean same. External maxillary artery means facial artery. In the old terminology, external maxillary artery which is being distributed into the face, that is facial artery. Internal maxillary artery means it is maxillary artery. So anterior tympanic artery is a branch arising from the first part, then middle meningeal artery from the first part, inferior tympanic, that is not a branch arising from the maxillary artery, then inferior alveolar artery is arising from the maxillary artery. So inferior tympanic, so it is anterior tympanic, not inferior, deep auricular, anterior tympanic. So answer is C. Which of the following statements is correct regarding deep artery of penis? So the main source of blood supply to the perineum is internal pudendal artery. Internal pudendal artery is a branch of internal iliac artery. Now here you find two pouches, superficial perineal pouch and deep perineal pouch. Internal pudendal artery reaches the or it passes through lesser sciatic foramen, then it passes through pudendal canal which is present within the lateral wall of ischiorectal fossa. In the lateral wall of ischiorectal fossa you find pudendal canal or Alcock's canal. Here it gives rise to inferior rectal artery. Inferior rectal artery is a branch of internal pudendal artery. Internal pudendal artery is a branch arising from internal iliac artery. Then inferior rectal artery arises from internal pudendal artery. Then it gives rise to perineal branch and a main artery which enters into the deep perineal pouch, which divides into deep artery of penis and dorsal artery of penis. Deep artery of penis enters into the corpora cavernosa. Dorsal artery runs just deep to the superficial, that means in the superficial face shape. Deep artery runs in the corpora cavernosa. In the penis you find three structures, two corpora cavernosa and corpus spongiosum. Corpus spongiosum is being traversed by urethra and corpora cavernosa contains deep artery of penis. Apart from that, it gives rise to urethral artery, and these perineal branches they give rise to posterior scrotal or labial vessels, posterior scrotal artery, and apart from that you find transverse perineal arteries. So the main source of blood supply to the perineal pouches and to the ischiorectal fossa is by the internal pudendal artery. So inferior rectal artery is arising at the level of ischiorectal fossa and deep artery of penis, dorsal artery of penis. Perineal branch is giving rise to posterior scrotal vessels and transverse perineal vessels. So which of the following statements is correct regarding deep artery of the penis? It is a branch of internal iliac artery. It supplies corpus spongiosum. It supplies corpora cavernosa and its main function is erection. It anastomoses with a superficial artery. So answer is it supplies Corpora cavernosa. The answer here is it supplies Corpora cavernosa. Now, what is present within the corpus spongiosum is urethra. Urethra passes through corpus spongiosum. External carotid artery is external carotid artery ligation is done just above the horizon of superior thyroid artery. Now, the various branches of external carotid artery. External carotid artery is a branch arising from the common carotid artery. The common carotid artery is terminating at the level of upper border of lamina of thyroid cartilage, and it divides into internal carotid artery and external carotid artery. The external carotid artery passes through the carotid triangle, enters into the digastric triangle, and then within the substance of the parotid gland, the artery terminates by dividing into superficial temporal and maxillary artery. So, origin of external carotid artery is at the upper border of lamina of thyroid cartilage. Then it is running within the carotid triangle, where it passes deep to posterior belly of digastric and styloid and enters into the digastric triangle. Then it pierces the posteromedial surface of parotid gland, enters into the substance of the gland, divides into superficial temporal artery and maxillary artery. Then, when the artery is present within the carotid triangle, it gives off a first branch called ascending pharyngeal artery. Then, superior thyroid artery. Then, facial artery. Lingual artery. So, from below upwards, superior thyroid, lingual, facial. Then, opposite to the facial, there is occipital artery, which is the source of blood supply to the posterior part of the scalp. Then, after entering into the digastric triangle, it gives rise to posterior auricular artery, which supply posterior part of the scalp. Now, superior thyroid artery, this branch of one side anastomoses with the superior thyroid artery of opposite side. Particularly the facial artery also. The facial artery also, the branches of facial artery of one side articulate with the branches of facial artery of opposite side. So, the ligation is done below the level of horizon of superior thyroid artery. Now, the superior thyroid artery anastomoses with inferior thyroid artery. Inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of subclavian artery. So, in superior thyroid artery is anastomosing with inferior thyroid artery, which is a branch of subclavian artery, and it is also anastomosing with superior thyroid artery of opposite side. So, ligation can be done below the level of superior thyroid artery, and no branch arises from common carotid artery, and no branch arises from cervical part of internal carotid artery. All the branches in the head and neck, they are being given by external carotid artery. So, it is being the ligation is done just below the horizon of superior thyroid artery. Superior thyroid artery is a branch of external carotid artery. Superior thyroid artery is a branch of external carotid artery, and the course of this artery is very closely related to a nerve, that is external laryngeal nerve. There are two sources of blood supply to the thyroid gland. So, if you see the lateral lobe of the thyroid gland, you find the apex and the base. The apex of lateral lobe of thyroid gland, the superior thyroid artery reaches, then it divides into an anterior branch and posterior branch. The posterior branch anastomoses with ascending branch of inferior thyroid artery, and then it divides into branches. Whereas superior thyroid artery anterior branch at the upper border of isthmus, it anastomoses with the anterior branch of opposite side. Now, the course of the superior thyroid artery is very closely related with external laryngeal nerve. This external laryngeal nerve is the nerve supply to cricothyroid muscle. Now, the artery and the nerve are very close to each other, far away from the gland. On approaching the gland, you can see the artery and nerve are deviating. The nerve is passing on to the medial side, then the artery is splitting up into two. So, the ligation of superior thyroid artery is to be done as close to the gland as possible. Inferior thyroid artery, this is a branch of thyrocervical trunk, which is arising from the first part of subclavian artery. Now, here the inferior thyroid artery distribution is closely related with recurrent laryngeal nerve. Recurrent laryngeal nerve supplies all the muscles of larynx except cricothyroid. Cricothyroid is supplied by external laryngeal nerve. Now here you can see the recurrent laryngeal nerve and inferior thyroid artery are far away from one another and they are closely related or approaching the gland. So inferior thyroid artery is to be ligated far away from the gland as possible, whereas superior thyroid artery is to be ligated as close to the gland as possible. So here the superior thyroid artery is a branch of external carotid artery. The common carotid artery on the right side, it is a branch arising from brachiocephalic trunk. On the left side, it arises directly from arch of aorta. Then facial artery is a branch of external carotid artery, and maxillary artery, already we have seen it is a branch of external carotid, is one of the terminal branch. Large terminal branch of external carotid artery is maxillary artery. Then descending vaginal artery is a branch of. So ovarian artery, it is a branch of abdominal aorta. Gonadal arteries, they arise from the abdominal aorta, be it ovarian artery or the testicular artery. Then the common iliac artery does not give any branches. Uterine artery gives rise to descending vaginal artery. Here vaginal artery, regarding vaginal artery, you have to understand two important points. Now the aorta is terminating by dividing into right and left common iliac arteries. This is at the level of L4, at the level of lower border of L4, the descending aorta or the abdominal aorta terminates into right common iliac artery, left common iliac artery. Then the common iliac artery divides into internal iliac artery and external iliac artery. External iliac artery continues as femoral artery at the mid-inguinal point. It enters into the femoral triangle at the mid-inguinal point. This external iliac artery gives off two branches. So one is inferior epigastric artery. Inferior epigastric artery is a branch of external iliac artery and deep circumflex iliac. These two are the branches of external iliac artery. Inferior epigastric artery and deep circumflex iliac. Then internal iliac artery. This divides into two divisions, anterior division and posterior division. The posterior division gives rise to superior gluteal artery, which is the source of blood supply to the gluteal region, then lateral sacral arteries and iliolumbar artery. These three are the branches arising from posterior division: superior gluteal, lateral sacral, iliolumbar. Whereas anterior division gives rise to superior vesical artery, that is to the urinary bladder, inferior vesical artery, then obturator artery, uterine artery. This inferior vesical artery, in case of females, you call it as vaginal artery, and uterine artery also gives off a branch to the vagina. So vaginal arteries are derived from uterine artery and also a direct branch from anterior division of internal iliac artery. So superior vesical artery, inferior vesical artery in case of females is referred to as vaginal artery. Then obturator artery, uterine artery, then inferior gluteal artery, internal pudendal artery. So these are all the branches, and apart from that, middle rectal artery. And we have already seen inferior rectal artery is a branch of internal pudendal artery. Middle rectal artery arises from internal iliac artery, whereas superior rectal artery is a branch of, or is a direct continuation of inferior mesenteric artery. So anterior division gives rise to superior vesicle, inferior vesicle to the urinary bladder. Inferior vesicle is also called vaginal artery. Then obturator artery, which supplies the medial compartment of thigh, uterine artery, inferior gluteal artery, then internal pudendal and middle rectal. Superior gluteal artery is a branch arising from the posterior division of internal iliac artery. Now here descending vaginal artery is a branch of uterine artery. Remember that gonadal arteries, they arise from aorta. Gonadal arteries arise from aorta. Even the gonadal veins, right gonadal veins are also very important clinically. Right gonadal veins, they drain into inferior vena cava, and left gonadal veins, they drain into left renal vein. Posterior intercostal arteries are the branches of. Now, in every intercostal space, there are 11 intercostal spaces. In every intercostal space, you find 3 arteries. One anterior intercostal artery and 2 posterior intercostal arteries. So, if you study the arteries in the thorax, so anterior intercostal arteries, they are the branches arising from internal thoracic artery. Internal thoracic artery is a branch arising from first part of subclavian artery. Internal thoracic artery is a branch arising from first part of subclavian artery, and that runs vertically downwards just by the side of the lateral border of the sternum, and in every intercostal space it gives rise to 2 anterior intercostal arteries. In the 6th intercostal space, the internal thoracic artery terminates by dividing into superior epigastric artery and musculophrenic artery. Superior epigastric artery enters into the rectus sheath and anastomosis with inferior epigastric artery. Now we have studied that inferior epigastric artery is a branch of external iliac artery. Superior epigastric artery is a branch of internal thoracic artery, a branch arising from first part of subclavian artery. So within the rectus sheath, there is an anastomosis between the branch artery of the upper limb and the artery of lower limb. Apart from that, the internal thoracic artery is the chief source of blood supply to the medial part of mammary gland through perforating branches present in 2nd, 3rd and 4th intercostal spaces. And it also gives rise to sternal branches, mediastinal branches, and in every intercostal space it is giving rise to 2 anterior intercostal arteries. Then the posterior intercostal arteries are the branches of descending aorta. Descending thoracic aorta gives rise to 1 posterior intercostal artery in every space. So, number of intercostal arteries present in each space 3. 1 posterior, 2 anterior. On reaching the angle of the rib, the posterior intercostal artery divides into 2 and anastomosis with 2 anterior intercostal arteries. So, that is the way how the anastomosis occur within the intercostal space. Now, what is the clinical importance of this anastomosis? Whenever there is now coarctation of aorta, usually preductal or postductal coarctation of aorta, the narrowing of aorta. Whenever there is a narrowing of aorta, now the blood to the lower part is being carried through this anastomosis. Blood from the subclavian passes through the internal thoracic artery. Internal thoracic artery is a branch. Now here arch of aorta is giving rise to a brachiocephalic trunk, left common carotid, left subclavian. Now the blood supply to the lower part of the body, that is through the descending aorta and abdominal aorta, is reduced. So the blood passes through subclavian artery, then internal thoracic artery, then anterior intercostal arteries, posterior intercostal arteries, then enter into the lower limb. Then this anastomosis becomes more prominent and the blood vessels, they become very wide and they produce notching of ribs. So notching of ribs is a characteristic feature what you see radiologically in case of coarctation of aorta. So that is importance of this anastomosis. So posterior intercostal arteries are the branches of now first posterior intercostal artery. Now here the subclavian artery. Subclavian artery can be divided into 3 parts by scalenus anterior muscle. So the first part of subclavian artery is giving rise to internal thoracic artery, thyrocervical trunk, which gives rise to inferior thyroid artery and vertebral artery. Second part gives rise to costocervical branch. This costocervical divides into superior intercostal and deep cervical. The superior intercostal gives rise to posterior intercostal arteries in the upper 2 spaces. Now what are the branches of thyrocervical trunk? Thyrocervical trunk gives rise to inferior thyroid artery, which is the chief source of blood supply to the thyroid gland and parathyroid glands. Apart from that, you find suprascapular artery, which is a main artery taking part in scapular anastomosis. Suprascapular artery. Transverse cervical artery. Suprascapular artery, transverse cervical artery, they take part in the anastomosis around the scapula. Inferior thyroid artery, anastomosis with superior thyroid artery. Now here, posterior intercostal arteries are the branches arising from aorta. and also the superior intercostal artery is giving off posterior intercostal arteries in the upper two spaces, and rest of the posterior intercostal arteries they raise from the descending aorta. So answer is A and B. Thyrocervical trunk. What are the branches of thyrocervical trunk? Is transverse cervical, suprascapular, which are taking part in the anastomosis around scapula, and apart from that you find inferior thyroid artery, which is not a branch of internal iliac artery. So already we have seen that ovarian artery is a branch of abdominal aorta, then uterine artery, that is a branch of internal iliac artery, superficial ilioinguinal artery. So what is a branch arising from the posterior division of internal iliac artery is from the posterior division of internal iliac artery you find iliolumbar artery. So inferior epigastric artery. Inferior epigastric artery is a branch of external iliac artery. Now here the only branch arising from internal iliac artery is uterine artery. So option A is wrong because ovarian artery is a branch of abdominal aorta. There is no superficial inguinal artery, ilioinguinal artery. It is iliolumbar artery. Then inferior epigastric artery. Inferior epigastric artery and deep circumflex iliac arteries are the branches arising from external iliac artery. So here the answer is B, and the question is which is a branch of internal iliac artery. All the rest of the three are not the branches of internal iliac artery, and only branch arising from the anterior division of internal iliac artery here is uterine artery. So the other branches we have seen just now. Femoral artery is a division of external iliac artery at the level of. So the femoral artery enters into the femoral triangle by passing deep to the inguinal ligament at the mid-inguinal point. So anterior superior iliac spine, then inguinal ligament, pubic tubercle and symphysis pubis. If you take a midpoint between anterior superior iliac spine and symphysis pubis, that becomes mid-inguinal point. If you take a midpoint between anterior superior iliac spine and pubic tubercle, that is a area where the inguinal ligament is extending. So that point you call it as midpoint of inguinal ligament. The nerve, the structure which is passing at the midpoint of inguinal ligament is femoral nerve. The structure which lies deep to midpoint of inguinal ligament is femoral nerve. The structure which enters into the femoral triangle at the mid-inguinal point is femoral artery. Femoral artery is a continuation of external iliac artery. Then already we have seen that there are two branches arising from external iliac artery. One is deep circumflex iliac artery and the other is inferior epigastric artery. Then the femoral artery passes through the femoral triangle from base to the apex. Then it enters into the adductor canal. At the fifth osteoaponeurotic opening in the adductor canal, the femoral artery terminates by continuing as popliteal artery. So the femoral artery is the main artery present in the anterior compartment of thigh, traversing the femoral triangle from base to the apex. Now here it gives rise to superficial epigastric artery. Previously what we have studied is superior epigastric, inferior epigastric. This is superficial epigastric artery. Superficial external pudendal artery. The superficial external pudendal artery supplies external genitalia. Superficial circumflex iliac. Deep circumflex iliac is a branch of external iliac artery. This is superficial circumflex iliac. So three superficial branches are given by femoral artery in the femoral triangle. Superficial epigastric artery, superficial external pudendal artery and superficial circumflex iliac artery. And the main source of blood supply to the posterior compartment of thigh, that is profunda femoris artery, and which arises 4 centimeters below the mid-inguinal point. Profunda femoris artery. Now the profunda femoris artery, after arising from the, now if you see the medial compartment of thigh, you find pectineus muscle, then adductor longus and gracilis. Then in the middle you find obturator externus, adductor brevis. Posterior part you find adductor magnus. The muscles in the medial compartment of thigh are arranged in 3 layers: pectineus, adductor longus and gracilis. This is obturator externus, then adductor brevis. adductor magnus. Now, profunda femoris artery is arising from femoral artery in the femoral triangle. Then it is leaving the triangle between pectineus and adductor longus, then adductor longus and adductor brevis, and it passes through fourth osteoeponeurotic opening present in the adductor magnus. Through fifth osteoeponeurotic opening, femoral artery is continuing as popliteal artery. Through fourth osteoeponeurotic opening, you find fourth perforating artery, which is the termination of profunda femoris artery. In the femoral triangle, profunda femoris gives rise to two lateral circumflex femoral artery and medial circumflex femoral artery. These two are the branches arising from profunda femoris artery in the femoral triangle. And then after passing into the medial compartment, it gives rise to first, second, third and fourth perforating arteries. So now finally, what are the branches of profunda femoris artery? Lateral circumflex femoral artery, medial circumflex femoral artery and four perforating arteries are given by profunda femoris artery. So that is the distribution of femoral artery in the femoral triangle. Then after entering into the adductor canal, femoral artery gives off only one branch, that is descending genicular branch, which take part in the anastomosis around the knee joint. So femoral artery gives off three superficial branches: superficial epigastric, superficial circumflex iliac, superficial external pudendal. The chief source of blood supply to the rest of the compartments of thigh is through profunda femoris artery, and that profunda femoris artery is giving off lateral circumflex, medial circumflex and perforating arteries. The importance of the second perforating artery is it provides nutrient branch to femur. The nutrient branch to femur almost always arises from second perforating artery. Then the other branch, the only branch given by the femoral artery in the adductor canal is descending genicular artery. So here femoral artery is a division of external iliac artery, is a continuation of external iliac artery at the level of mid-inguinal point. At the midpoint of inguinal ligament, the structure which is entering into the femoral triangle is femoral nerve. The branches of external carotid artery does not include. So just now we have seen the branches of external carotid artery. Facial artery, lingual artery, maxillary artery, inferior thyroid artery is a branch of thyrocervical trunk. The other branches arising thyrocervical trunk in turn is a branch of first part of subclavian artery. And the other branches arising from thyrocervical trunk apart from inferior thyroid artery are suprascapular artery and transverse cervical artery, which take part in the anastomosis around scapula. So that anastomosis is also we can quickly review. So there is an anastomosis between first part of subclavian artery and third part of axillary artery. So if it is a scapula, the third part of axillary artery gives rise to subscapular artery. In the middle, subscapular artery gives off circumflex scapular artery. From the first part of subclavian artery, this is from the third part of axillary artery. From the first part of subclavian artery, you find thyrocervical trunk. This thyrocervical trunk gives rise to suprascapular artery and transverse cervical artery. So, suprascapular and transverse cervical branches of thyrocervical trunk and subscapular artery of third part of subclavian artery, third part of axillary artery, they take part in the anastomosis around scapula. So, whenever there is a block between first part of subclavian artery and third part of axillary artery, this anastomosis becomes more prominent, what you call it as anastomosis around scapula. Ascending aorta is derived from truncus arteriosus. Now in the primitive heart tube, so the heart is developed from two endothelial heart tubes. You find two aortae, two endothelial heart tubes, they join together to form primitive heart tube. That primitive heart tube is divided into four segments. The caudal end you call it as sinus venosus. Middle part is called primitive atrium, then primitive ventricle, bulbus cordis. Distal part of bulbus cordis is called truncus arteriosus. Now these are the four segments of the primitive heart tube: sinus venosus, primitive atrium, primitive ventricle, bulbus cordis, truncus arteriosus. Now if you grossly describe, sinus venosus receive the blood from the body wall through common cardinal vein. Common cardinal vein is formed by the union of anterior cardinal vein and posterior cardinal vein. Then from the placenta through umbilical vein. Then from the gut through vitelline vein. This is common cardinal vein. The sinus venosus is receiving the blood from three sources. From the body wall, it is receiving the blood from common cardinal vein, anterior cardinal vein, posterior cardinal vein. It is receiving oxygenated blood from placenta through umbilical vein. It is receiving deoxygenated blood, poorly oxygenated blood from the gut through vitelline veins. So you find a pair of vitelline veins, a pair of umbilical veins, and a pair of common cardinal veins. Now these umbilical veins and vitelline veins, they pass through septum transversum, into which the liver grows. Because they are passing through septum transversum, when the liver grows, the longitudinal continuity of these blood vessels is broken up. And those broken pieces of these blood vessels, they contribute to the sinusoids of the liver. Now, umbilical veins, vitelline veins are broken up into suprahepatic segments and infrahepatic segments. Now, infrahepatic part of right umbilical vein disappears. Now, what is left over within the umbilical cord is left umbilical vein. Left is left. Okay. So, in the umbilical cord, you find only one umbilical vein and you find two umbilical arteries. The structures present within the umbilical cord are one umbilical vein and two umbilical arteries. What is that umbilical vein? It is the left umbilical vein. Right umbilical vein, right infrahepatic part regresses. So, all the oxygenated blood is being brought through the left umbilical vein. Then these vitelline veins are involved in the formation of portal vein. Vitelline veins, they give rise to portal vein. Then suprahepatic segments. Right umbilical vein disappears. Left umbilical vein disappears. Left vitelline vein disappears. Now all the blood which is brought by the vitelline veins, umbilical veins, which is poured into the liver, is being poured into the primitive heart tube only through right vitelline vein, suprahepatic part of right vitelline vein. This is what you call it as hepatocardiac channel. The terminal part of inferior vena cava is formed by this hepatocardiac channel. So, what are being derived from umbilical veins? All the umbilical veins, they disappear except infrahepatic left umbilical vein that remains within the umbilical cord. After birth, now here you see, all the oxygenated blood is being brought to the liver by means of left umbilical vein. Now, to bypass hepatic circulation, there is no need of blood going, oxygenated blood going to the liver. So, to bypass the hepatic circulation, a vessel is formed between the left umbilical vein and the hepatocardiac channel, which in future is going to give rise to inferior vena cava. That is what you call it as ductus venosus. Now, what is the function of this ductus venosus is to shunt this oxygenated blood directly to the inferior vena cava. Now, after birth, once you cut the umbilical cord, this left umbilical vein is fibrosed to form ligamentum teres hepatis. Ligamentum teres hepatis. Now, what is the remnant what you find in the adults is left umbilical vein forms ligamentum teres hepatis, and there is no blood going through this ductus venosus after birth. So, this is fibrosed to form ligamentum venosum. Ligamentum venosum. Now, what is the fate of these vitelline veins means? Infrahepatic parts of right and left vitelline veins, they form the portal vein, and suprahepatic part of right vitelline vein forms the terminal part of inferior vena cava. Now, what about these cardinal veins? So, you find right and left cardinal veins, anterior cardinal vein and posterior cardinal vein. Anterior cardinal veins, they collect the blood from the anterior part of the embryo and they join with posterior cardinal vein. These two are common cardinal veins. Common cardinal veins, they are opening into the corresponding horns of sinus venosus. Now, the two anterior cardinal veins are connected by an anastomosis. Now, all the blood from left side is shunted to the right side. The left anterior cardinal vein regresses. So, part of anterior cardinal vein cranial to this anastomosis forms right brachiocephalic vein. Left brachiocephalic vein is formed from left anterior cardinal vein and this anastomosis. That is the reason why left brachiocephalic vein is more oblique and more long when compared to the right brachiocephalic vein. Then the rest of the anterior cardinal vein and common cardinal vein forms superior vena cava. So superior vena cava is derived from two sources, right anterior cardinal vein and right common cardinal vein. Then what about this left common cardinal vein? The left common cardinal vein and the left horn of sinus venosus. The left horn of all the blood is now brought to the right horn of sinus venosus. You can see vitreous vein is draining into right horn of sinus venosus. Even common cardinal vein is also blood is draining into right horn of sinus venosus. So gradually what happens? Left horn of sinus venosus, left common cardinal vein, they gradually get regressed. And this narrow blood vessel forms coronary sinus. Coronary sinus is the large vein which drains the heart. So that coronary sinus is being derived from the left horn of sinus venosus and left common cardinal vein. Then if you see the development of this posterior cardinal veins, what is the fate of this posterior cardinal veins? So posterior cardinal veins, they are collecting the blood from the pelvis through internal iliac vein and from the lower limb through the external iliac vein. These two are being connected by means of a vessel. A transverse anastomosis is established. Now kidneys are draining the blood into subcardinal veins. So a pair of new set of veins are being formed in relation to intermediate mesoderm from which kidneys are developed. These are called subcardinal veins. Now kidneys, they are draining the blood into the subcardinal veins and these subcardinal veins, they are establishing a communication with the posterior cardinal veins. Then lateral to subcardinal vein, another set of veins drain the body wall. These are called supracardinal veins. So a pair of subcardinal and a pair of supracardinal veins are being formed. Posterior cardinal veins are collecting the blood from pelvis and lower limb. Subcardinal veins are collecting the blood from intermediate mesoderm. Supracardinal veins are collecting the blood from the body wall. Now, two subcardinal veins are interlinked by intersubcardinal anastomosis. Now, subcardinal vein and supracardinal vein are connected by supracardinal subcardinal anastomosis. Now, you see the development of inferior vena cava. This subcardinal vein is establishing a communication with hepatocardiac channel. Inferior vena cava, the first segment of inferior vena cava is developed from right posterior cardinal vein. That is first segment. Second segment is developed from right supracardinal vein. The third segment is developed from subcardinal supracardinal anastomosis. The fourth segment is developed from right subcardinal vein. The fifth segment is developed from subcardinal hepatocardiac anastomosis. The sixth segment is developed from hepatocardiac channel. So there are two segments. There are six segments from which inferior vena cava is developed. The first segment from right posterior cardinal vein, second from right supracardinal vein, third from subcardinal supracardinal anastomosis, fourth from subcardinal vein, fifth from subcardinal hepatocardiac anastomosis, sixth from hepatocardiac channel. Now, you see the site where the renal veins are opening. Renal veins are opening into the fourth segment. That means, renal segment of inferior vena cava is developed from subcardinal vein. Hepatic component of inferior vena cava is developed from hepatocardiac channel. That is, suprahepatic part of right vitelline vein. So, what is the renal segment? What is the source of renal segment of inferior vena cava? That is right subcardinal vein. Now rest of the subcardinal veins and supracardinal veins, they disappear. Now you can see the cranial part. Now here renal veins, if you see the development of renal veins, right renal vein is developed from mesonephric vein. The original vein of right kidney, which is draining into subcardinal vein, is forming the right renal vein. But left renal vein is developed from left mesonephric vein, left subcardinal vein and intersubcardinal anastomosis. Now you can understand embryologically why left renal vein is longer when compared to the right renal vein. Which renal vein is more longer? Right renal vein is 2.5 centimeters. Left renal vein is 7.5 centimeters. The reason for that is right renal vein has got only one source, that is right mesonephric vein. The left renal vein has got three sources: left mesonephric vein, left subcardinal vein and intersubcardinal anastomosis. Now the cranial part of subcardinal veins, they form suprarenal vein. The caudal part of subcardinal veins, they form gonadal vein. Now you can understand why right side suprarenal vein and right side gonadal veins, they drain into inferior vena cava, and left side suprarenal vein and left side gonadal vein, they drain into left renal vein. So what is the source of suprarenal vein? Suprarenal veins are developed from subcardinal veins. Where from gonadal veins are developed? They are developed from subcardinal veins. What is other vein which is developed from right subcardinal vein? That is inferior vena cava and a small portion of left renal vein. What about supracardinal veins? Right second segment of inferior vena cava is developed from right supracardinal vein. Rest of supracardinal veins, they completely disappear. Now all the venous blood is reaching the right horn of sinus venosus. Now this right horn of sinus venosus is absorbed into the right atrium. In the right atrium, now you find two components. In the right atrium, you find smooth part and rough part. Smooth part is developed from this right horn of sinus venosus and rough part is developed from primitive atrium. What is the fate of left horn of sinus venosus and left common cardinal vein? That is forming coronary sinus. Now what about this chamber, primitive atrium? The primitive atrium, you find it is being partitioned to form right and left atria. The septum which is formed here is interatrial septum, which is developed from septum primum, which is a membranous septum. Now here between primitive atrium and primitive ventricle, you find atrioventricular canal, that is subdivided by septum intermedium into right atrioventricular orifice and left atrioventricular orifice. From the roof of primitive atrium, you find a septum growing down. That septum you call it as septum primum, which is a membranous septum. Gradually that comes and fuses with septum intermedium. Now in the upper part of septum primum, a opening is formed, that is called foramen secundum. Before the septum primum comes and fuses with septum intermedium, you find a gap between the lower margin of septum primum and septum intermedium. That gap you call it as foramen primum. In the upper part of septum primum, you find another gap, that is called foramen secundum. On the right side, you find septum secundum. Gradually that comes and overlaps the septum primum. Now you find a membranous gap between lower margin of septum primum and upper margin of lower margin of septum secundum and upper margin of septum primum. That is what you call it as foramen ovale. So throughout the intrauterine life, you find the blood which is brought by inferior vena cava is shunted into the left side through foramen ovale. Then primitive ventricle. Primitive ventricle is being subdivided into right and left ventricles by the formation of interventricular septum. Interventricular septum, major part of interventricular septum is arising from the floor of the primitive ventricle, and in the bulbus cordis a septum forms, that is what you call it as bulbar septum. Then from the endocardial cushion, this gap between the bulbar septum and the primitive or ventricular septum proper is being closed. So interventricular septum is developed from three sources. Distal part of interventricular septum or membranous part, it is being developed, or towards the bulbus cord it is being developed from bulbar septum. Then muscular part is being developed from ventricular septum proper, and the gap between the two is being filled by proliferation of endocardial cushions. So what is the fate of sinus venosus? Right horn of sinus venosus is taken up by right atrium, left horn of sinus venosus is forming coronary sinus. What is the fate of primitive atrium? It is there forming the corresponding rough portions of atria. Primitive ventricles, they form the rough part of ventricles. Smooth outflowing part of the ventricles is formed by bulbous cordis. Now, a septum is formed within the truncus arteriosus, that is what you call it as aorticopulmonary septum, that divides the truncus arteriosus into ascending aorta and pulmonary trunk. So, ascending aorta and pulmonary trunk are developed from truncus arteriosus. It is being subdivided into two. So, what is primitive right ventricle? Primitive right ventricle means that is being contributing to the right ventricle. Then ventral aortic sinus, that is distal to the truncus arteriosus, you call it as aortic sinus, that contributes to the formation of arch of aorta. Then arch arteries, later we will see it subsequently. So ascending aorta and pulmonary trunk, ascending aorta and pulmonary trunk are developed from truncus arteriosus. The septum which is formed in the truncus arteriosus is called spiral septum. If that spiral septum does not form, then you find the ascending aorta and pulmonary trunk, both of them, they are communicating with one another, and you find a common blood vessel, common blood vessel. And if there is no proper development of this spiral septum, then you find the abnormal communication between this, that means transposition of great vessels is due to the formation of abnormal development of that spiral septum. Which is not true concerning descending aorta, descending thoracic aorta. Descending thoracic aorta gives rise to bronchial arteries, and just now we have seen it is giving rise to intercostal arteries, posterior intercostal arteries arising from descending aorta. It enters into the abdomen at the level of 12th thoracic vertebra, and then esophagus passes from left to right side. Here, so now you find three parts in the aorta: ascending aorta, then there is the arch of aorta, and then the descending aorta. Ascending aorta is arising from the left ventricle, and that at the level of right second costal cartilage, that is at the level of sternal angle, it is continuing as arch, and the arch continues as descending at the level of lower border of T4 vertebra, and the descending aorta enters into the diaphragm through aortic opening, which is present at the level of 12th thoracic vertebra. There are three openings present within the diaphragm. One is vena cava opening at the level of T8, esophageal opening at the level of T10, and aortic opening at the level of T12. The branches arising from the ascending aorta are coronary arteries. The right coronary artery and left coronary artery, they are the branches of ascending aorta. And then arch of aorta gives rise to brachiocephalic trunk, left common carotid artery, and left subclavian artery. Then the descending aorta. Descending aorta gives rise to posterior intercostal arteries. Then bronchial arteries, and this you have to carefully remember. The bronchial arteries, right bronchial artery arises from right third posterior intercostal artery. Right bronchial artery is usually 1 in number, and that arises from right third posterior intercostal artery. And what arises from descending aorta are left bronchial arteries, which are usually 2 in number. Left bronchial arteries are 2 in number. They are the branches arising from descending aorta. Right bronchial artery is usually 1, and that arises from right third posterior intercostal artery. Then it gives rise to esophageal branches, superior phrenic artery. Inferior phrenic is a branch of abdominal aorta. This supplies the diaphragm. Superior phrenic artery, then pericardial branches to the pericardium. So those are the main branches arising from the descending aorta. So here answer A is correct. It is it gives rise to left bronchial arteries. Left bronchial arteries are the branches of descending aorta. It gives rise to intercostal arteries. Posterior intercostal arteries they arise from the descending aorta, except first two intercostal spaces. In the first two intercostal spaces, the posterior intercostal arteries are the branches of costocervical trunk from the superior intercostal artery. Then it enters into the abdomen at the level of T12 vertebra. Then esophagus passes from right to left side. So the statements are correct. Which of the following is not a branch of internal iliac artery? Obturator artery is a branch of internal iliac artery. Inferior epigastric artery, that is a branch of external iliac artery. Then internal pudendal artery is a branch of internal iliac artery. Uterine artery is a branch of internal iliac artery. So answer is inferior epigastric artery. That is a branch of external. There are two branches arising from external iliac artery. One is inferior epigastric artery and the other is deep circumflex iliac artery. And the other important clinical point you have to remember this regarding inferior epigastric artery is, after arising from the external iliac artery, it has to enter into rectus sheath. It is related with inguinal canal. There is deep inguinal ring. Inferior epigastric artery passes on the medial side of the deep inguinal ring, then it enters into the rectus sheath. It gives off a pubic branch which anastomoses with pubic branch of obturator artery. The pubic branch of obturator artery and the pubic branch of inferior epigastric artery, they anastomose with one another. Sometimes this obturator artery may not be prominent, then this inferior epigastric artery, pubic branch of inferior epigastric artery is more prominent. This is what you call it as abnormal obturator artery. Abnormal obturator artery, which causes severe hemorrhage during femoral hernia surgery, abnormal obturator artery. So that is an anastomosis between pubic branch of inferior epigastric artery and pubic branch of obturator artery. And the other point what you have to remember is, what is the relation between the deep inguinal ring and inferior epigastric artery? Inferior epigastric artery is medial to deep inguinal ring. The contents, if they enter into the inguinal canal through deep inguinal ring, that is what you call it as indirect inguinal hernia. In that condition, the sac of the hernia lies lateral to the inferior epigastric artery. In case of direct hernia, the sac lies medial to the inferior epigastric artery. So then, inferior epigastric artery enters into the rectus sheath and it terminates by anastomosing with superior epigastric artery, which is a branch of internal thoracic artery. So obturator artery, internal pudendal artery, uterine arteries, all those are the branches of internal iliac artery. Inferior thyroid artery. Inferior thyroid artery is a branch of thyrocervical trunk. Subclavian artery, on the right side it is a branch of brachiocephalic trunk, on the left side it is a branch of arch of aorta. Then intercostal arteries already you have seen. In every space you will be finding three intercostal arteries. Anterior are the branches of internal thoracic artery and one posterior is the branch of descending aorta. The external carotid artery is given off by common carotid artery at the level of upper border of lamina of thyroid cartilage. And thyrocervical trunk. Thyrocervical trunk gives off two more branches, that is suprascapular artery and transverse cervical artery. Blood supply to the external nose is derived from the now here you can see the facial artery. Main source of blood supply to the lateral side of the nose is by the facial artery. So external carotid artery, after arising from the facial artery, external carotid artery, after giving off a facial artery within the carotid triangle, it enters into the digastric triangle, where it is closely related to submandibular gland. Then it winds round the inferior border, enters into the face, where it lies half inch lateral to the angle of mouth. Then it passes by the side of the nose and it terminates by anastomosing with dorsal nasal branch of ophthalmic artery. Dorsal nasal branch of ophthalmic artery. So the main source of blood supply is by the nasal branches given by facial artery. And this facial artery, facial part gives rise to superior labial artery and inferior labial artery, which anastomose with the similar branches of opposite side. Superior labial artery gives off a septal branch which take part in the formation of Little's area. Then the cervical part of facial artery is important. This part gives rise to glandular branches which supply the submandibular gland. Ascending palatine artery, this is the chief source of blood supply to the palatine tonsil. Then it gives off direct tonsillar branches to the palatine tonsil. Those are the main, and apart from that it gives rise to submental artery. So these are the main branches which are arising from the cervical part of the facial artery. Remember that ascending palatine artery and tonsillar branches, because facial artery is the chief source of blood supply to palatine tonsil. And dorsal nasal branch is a branch of ophthalmic artery. So here both ophthalmic and external maxillary arteries, they supply the external nose. External maxillary artery means facial artery. Gastroduodenal artery is a branch of Here, you have to understand the blood supply of the abdomen. Where there is abdominal aorta, the artery of foregut is celiac trunk, the artery of midgut is superior mesenteric artery, and the artery of hindgut is inferior mesenteric artery. These are the three branches which are supplying the gastrointestinal tract. Now, celiac trunk. Celiac trunk is a branch arising from the abdominal aorta at the level of L1 or at the level of lower border of T12. Then superior mesenteric artery at the level of between L1 and L2. At the level of L3 is inferior mesenteric artery. Now, celiac trunk divides into three branches. It gives rise to splenic artery. The largest branch of celiac trunk is splenic artery. Then left gastric artery, common hepatic artery. These are the three branches arising from celiac trunk. Left gastric artery, splenic artery, common hepatic artery. Largest branch is splenic artery, which undergoes a tortuous course along the upper border of the pancreas. And then it reaches the hilum of the spleen, where it supplies the spleen. It gives off short gastric branches to the fundus of stomach and left gastroepiploic artery. Left gastroepiploic artery is a branch of splenic artery. Then throughout its course, it gives off a number of branches to pancreas. So the chief source of blood supply to the pancreas is splenic artery. So splenic artery is tortuous in course, runs along the upper border of the pancreas, and then it reaches the hilum of the spleen, and then it gives rise to short gastric branches to the fundus and left gastroepiploic artery. Then left gastric artery is reaching the gastroesophageal junction, then it supplies the lower part of esophagus and then runs along the lesser curvature of the stomach. This is common hepatic artery. The common hepatic artery gives rise to hepatic artery proper, which divides into right and left branches. This is hepatic artery proper. That hepatic artery gives rise to right branch of hepatic artery. Right hepatic artery gives rise to cystic artery. It supplies the gallbladder. So cystic artery is a branch of right hepatic artery. Then right gastric artery. This supplies this anastomosis with left gastric artery. And the other branch is gastroduodenal artery, which runs behind the first part of duodenum and then divides into right gastroepiploic artery and superior pancreaticoduodenal artery. Superior pancreaticoduodenal artery and right gastroepiploic artery. These two are the branches of gastroduodenal artery. And remember that gastroduodenal artery runs behind the first part of duodenum. So whenever there is a duodenal ulcer in the posterior wall, that ulcer, if it perforates, it erodes the gastroduodenal artery. So what is the artery of duodenal hemorrhage? It is the gastroduodenal artery. Then superior pancreaticoduodenal and right gastroepiploic artery. So those are the branches arising from celiac trunk. So now gastroduodenal artery is a branch of hepatic artery. Common hepatic artery is giving rise to hepatic artery, gastroduodenal artery, and then right gastric artery. What are other branches from celiac trunk is splenic artery and then left gastric artery. Remember, left gastroepiploic artery is a branch of splenic artery. Right gastroepiploic artery is a branch of gastroduodenal artery. Short gastric branches are the branches of splenic artery. Then superior mesenteric artery. Superior mesenteric artery runs within the root of mesentery. This gives rise to inferior pancreaticoduodenal. So this you have to understand carefully. Inferior pancreaticoduodenal artery is a branch of superior mesenteric artery. Then this gives rise to a number of jejunal and ileal branches, which anastomose with one another to form a number of arterial arcades. From these arterial arcades, vasa recta arises, and those they supply the jejunum and ileum. As you pass down from jejunum to ileum, number of arterial arcades increase. So vasa recta are short in ileal mesentery and vasa recta are long in jejunal mesentery. Number of arterial arcades are less in jejunal mesentery, number of arterial arcades are more in ileal mesentery. And then vasa recta are the examples for end arteries. Then it gives rise to ileocolic artery, which divides into ascending branch and descending branch anastomosis with superior mesenteric artery. This descending branch gives rise to appendicular artery and thecal artery. Then right colic artery, which anastomosis with middle colic artery, which divides into right branch and left branch. So the branches of superior mesenteric artery are inferior pancreaticoduodenal, jejunal and ileal, ileocolic, right colic, middle colic. Appendicular artery is a branch of ileocolic. Then right colic, middle colic. These arteries, they are anastomosing with one another and they supply ascending colon and right 2/3 of transverse colon. Then if you see the inferior mesenteric artery. Inferior mesenteric artery arising from abdominal aorta, it continues as superior rectal artery. Now we understood superior rectal artery is a branch of inferior mesenteric artery, middle rectal artery is a branch of internal iliac artery, and inferior rectal artery is a branch of internal pudendal artery. Then this inferior mesenteric artery gives off left colic artery. Then sigmoidal branches which are anastomosed with one another. So left colic is a branch of inferior mesenteric. Middle, right and ileocolic are the branches of superior mesenteric. Now all these arteries, ileocolic, right colic, middle colic, then left colic and sigmoidal branches, they anastomose with one another and to form an arterial arcade on the concavity of large intestine. So that is what you call it as marginal artery. So marginal artery is formed by ileocolic, right colic, middle colic, left colic and sigmoidal branches. And sometimes if this anastomosis between middle colic and right colic is not prominent, you find a vessel which is connecting the trunk of left colic and this middle colic artery. That is what you call it as arc of Riolan. So here gastroduodenal artery is a branch of hepatic artery. Then remember the splenic artery is the chief source of blood supply to the pancreas also. Arteria pancreatica magna, arteria cauda magna, they are developed from the splenic artery.